Hi, everybody. I want to make sure this is working the way it's supposed to, and it does look like it. All right. I don't have a lot to share with you today. That's why I'd rather do this dictation now, at 8 o'clock in the morning on Friday, as opposed to having you there for an extra hour in class this afternoon. More time to do whatever you have to do for the weekend and get studying for finals. Kind of where we left it. Quick review. Big deal here. When we're talking about the menstrual phase, again, starts with menstruation. Okay, typically they have permit 4 or 5 days, depending on who the author is with regards to when they publish these things. But the reality is, the big deal here is the luteal surge. That enormous spike. I mean, everything else is pretty straightforward. After menstruation, again, at this point, basically the the uterus and the stratum functionalis is beginning to develop. It's that luteal surge that has that big impact on ovulation. That's the part to know. After that, they both decline to relatively base levels, still present, but not extraordinarily high. Here you can see the relationship of what's going on when we look at the ovarian phases and the uterine phases. So here, as you can see, that dominant follicle is already at the start of that cycle. We're already in the ovarian cycle for 4 days, eventually developing that dominant follicle, and there's ovulation with luteal surge. This is during the proliferative phase of the uterine. And again, the distinction is follicular, know the terms: follicular phase, luteal phase, proliferative phase, secretory phase. And here, after ovulation, now we're in the luteal phase, the development of the corpus luteum, and then after 10 days, the deterioration of said corpus. And then, as you can see, estrogen has played a major role during the proliferative phase. Okay, estrogen played a major role during those early phases, and you can see that there is a little bit of a spike as we get toward the end of that particular phase. But notice, after ovulation, boom. I can't really tell you it accounts for the spike. Does it have something to do with ovulation? Possibly. Okay. But here you can see the predominant then production is progesterone. That's what maintains the stratum functionalis for implantation. And then again, you can see what's going on vis-a-vis with regard to what's going on in the endometrium. And then they just put some all together. Different things. We know that physical activity can, and there's a variety of factors that you can imagine can impact normal menstruation. And again, this is we're delaying it, and we've talked about this endlessly. The body fat relationships, so important to produce that leptin that plays that role in puberty. Lack of leptin can shut down the reproductive cycles. I don't want to get into it, but sports are big business, and the athletes are commodities, whether they are very young or very old or somewhere in between. Here's my blame, the preaching point. Look, if you're a professional football player or a professional athlete making millions of dollars, you realize that you're an asset, and they're going to do you what you want to do. If you don't want it, you don't have to play anymore. Leave and just give up the money. So all of these types of things. Young, healthy women can still see dramatic bone loss like osteoporosis, usually seen in old age. Okay, so if we've got the role of the body fat is just so important. There. Estrogens, obviously, oogenesis, follicular growth, anabolic effects, all these, the growth spurts that are associated with puberty, all of the secondary sexual characteristics we're all familiar with. As you can see them here, facilitating calcium uptake. That's the role. That's osteoporosis back last term. Maintains low total blood cholesterol and high LDL levels. That's all good. That's the so-called quote-unquote good cholesterol. That's what you want from exercise and activity. This is the one, you want to keep that number down. Progesterone, obviously they work in concert together. Changes in the cervical mucus, all about the placental progesterone during pregnancy, inhibiting uterine motility, prepare the best for lactation, all of those things. And they summarize it nicely here. Again, sexual response, you can read that as well as I can read it to you. All of those types of things are pretty standard. Again, parasympathetic for arousal, sympathetic for climax, obviously. There's no refractory period, unlike the male. Okay, and again, orgasm, as we know, is not essential for conception. Again, we feel that adrenocortical androgen, it probably plays a significant role in female libido. You know, I suspect that that's true. I certainly do not know, not an expert in that. The last little nugget of all this is sexually transmitted infections. This will probably take about 5 minutes because there's a couple of questions on it. STDs, STIs, venereal diseases, they're all the same. That statement alone, even though this is probably 8 years old, and I'm sure it hasn't changed, is ridiculous. Why is the country with the best health care overall? Why does the country that has a very well educated population, access to medical care, have this problem? Lack of education, reluctance for open discussions about sexual activity. We're very provincial. Moms and dads don't talk about this in the dinner table. I'm sure I've mentioned this before. You go into a European family, there's this common discussion. They don't do that. And again, I, of course, was an expert about that. My discussions about this, even though my first wife and I were very open about these kinds of things with our children, guess what? I'm a grandpa at oh, grandpa. So 2001, whatever. I'm a 50-year-old grandpa. Okay, you get the idea. My daughter had her daughter before she was 16. Now, understand, there's a variety of ways. There are basically reliable ways. And depending on the degree, I don't know how to phrase it, depending on the degree of how much impactful they are with regard to lifestyle or to health. I mean, there's always going to be complications. Whatever, if you're using an intrauterine device, certainly the pill is a powerful medication. Everybody has their own feeling about that, condoms and various other types of barrier methods. They spoil the moment and blah, blah, blah. Hey, understand, we're talking here about the disease aspect, and it's really a significant problem. And what I will say to every class, and I've said it a bunch of times, if your behavior is your behavior, do it however you want. However, be responsible. I'm saying responsible means get yourself checked. If you have frequent partners, if you would rather have unprotected intercourse, and you make your decision about how you're going to proceed. But at least be responsible to yourself and to whoever your partners are. It doesn't matter. I don't think anything else matters with regard to that. I think that's just being responsible and adult about the whole thing. Hey, I provide the information, you respond to it. Most common bacterial STI or STD in the United States, chlamydia trachomatis, is more common now. And the reason is, as opposed to gonorrhea, this doesn't hurt as much. Yes, big problems in the birth canal, just like gonorrhea. Why we mandatorily use antibiotics in babies' eyes. Tremendous pelvic inflammatory disease is extraordinarily destructive. We're talking about, again, ectopic pregnancies, early onset hysterectomies, infertility problems. Well, and it's a discharge disorder, the way we classify it. It's more painful in the man, but not always as painful, certainly as gonorrhea, which is extraordinarily painful. And they are painful. Understand, it's just a matter of degree, much less so in the female. There's all of those kinds of things, as you can see, described here with the typical symptoms that are there. You diagnose it by a smear of the discharge, whether it's penile discharge or vaginal discharge, and go from there. And basically, then sent to the laboratory, and they can make the diagnosis. It's almost a diagnosis of exclusion, meaning if it's not gonorrhea. In the old days, we talked about it was either gonorrhea or what we called non-gonococcal or non-specific urethritis, meaning it wasn't gonorrhea, it was something else. But now we know about chlamydia and we know about Trichomonas vaginalis, which is a protozoan. Relatively easy to treat it. It's a gram-negative. The difficulty is it doesn't have a well-defined cell wall, so cell wall antibiotics don't work. Z-Paks work very well. Vancomycin, which is doxycycline, which is a tetracycline derivative, work very well. So it's relatively easily treatable. As you can see, a minimal amount of symptomatology that's there. And again, the whole idea is really the biggest problem with conjunctivitis, what we call trichomas. We're also seeing pneumonias. This is for untreated active infections in the birth canal. That's why it's so important for prenatal care. Trichomoniasis or Trichomonas vaginalis, which is a protozoan. More common in women than in men. Very easily treated. Metronidazole flagyl works great. It's the drug of choice. We use that for anaerobic bacterial infections, but this is an anaerobic organism. And a lot of protozoans are. When you hear about somebody getting contaminated well water, it's usually giardiasis or amoebic dysentery. Those are protozoans. Treatment of choice, metronidazole or flagyl. The discharge is a little bit more identifiable, and it motivates by flagella, and we can see on the smear little sort of like twitching that occurs, which you can observe microscopically, and that sort of twitching motility is a big tell. Typically, what will happen in a doctor's office, they'll take the drainage, they'll put it on a slide. A lot of times, they'll just prep the slide and send it to the laboratory because they want a reliable diagnosis. But in our office, I didn't mind doing gram stands just to get a quick look. See, even though I said most of them out, but I was more than happy to do that. But I kind of did that afterwards, for my own information as opposed to anything else. Gonorrhea, not as making a big comeback as all of these are. See now, there's treatment for HIV, and there's not all sorts of noise. I think there's no saying about out of sight. It didn't go away. But now people are, now they're going back to the same mentality. Well, I guess something's treatable. Gonorrhea is extraordinarily destructive. Gonorrhea was rampant. I can't even tell you how many cases a day we saw in the emergency room back in the 70s. Okay, Neisseria gonorrhea, it is number one. In an adult who gets septic arthritis, it's gonorrhea until proven otherwise. It adheres to everything. Once it gets into the bloodstream, it's a gram-negative. Produces nasty complications. Its cousin, Neisseria meningitidis, is the leading cause in adults of Neisseria, bacterial meningitis. This could even cause this. This could cause pneumonia. This is the reason they started using not just eye drops, but originally silver nitrate drops in the eyes, because this was a tremendous cause of blindness. This is totally BS. Most infections are extraordinarily symptomatic. It's very painful. It's pus. It's nasty. It gets thick in the male penis. We've heard about this. It's almost like clogged. It's almost like popping a cork first thing in the morning. Extraordinarily painful. It leads to constriction. You need to have corrective surgery for it. It's a freaking minefield. Okay, all of the types of things that are there. We used to be very sensitive to basic penicillins. Now, typically cephalosporins are utilized. Sometimes they'll use cephalosporin. It's a gram-negative, so they'll probably use a cephalosporin and maybe something more specific to gram-negatives. Let's say ciprofloxacin, which is a hydroxyquinolone, very useful for gram-negatives. They're there. So I'm just speculating. It's not something I treated in my practice. Back when back in the day, it was basically treated with penicillin, because we didn't see the abundance of resistance that was there. And then the one we've known about the longest. I mean, we're talking about a disease that, way back in ancient times. It's very interesting. Called Treponema pallidum. Means the pale thread. It's a spirochete. Very similar in the fact that the response is all about your immune system rather than the damage it does. Like another gram-negative microaerophilic spirochete called Borrelia burgdorferi. That's Lyme disease. And it was rampant. So it's very easy to transmit. The thing is, we can't grow it in the laboratory. It's the thing that Koch's postulates of growing something in the lab and being able to create like a chain of evidence do not apply to this, because we've never been able to grow in the laboratory. We can see it under the microscope. We test for it indirectly. Fluorescent treponemal antibodies for years. We had to, in nearly every state in the union, except for I think West Virginia and Vegas, that's where you got quickie marriages, you had to have a blood test for syphilis. My first wife and I did here in Pennsylvania in 1978. It wasn't to stop the wedding. It was to identify if you were carriers or had been exposed to syphilis. and to get yourself treated and identify partners to try to get it under control. Okay? And the thing is, we do what we call hard chancre or canker, depending on who pronounces it, on the genitalia, very obvious in the male, not so obvious all the time in the female. It goes away. People think I'm better. But the reality is, even though it's teeming with spirochetes, now it's effectively has gone to your bloodstream and begins to spread throughout your body. And now you get this, after a sort of I hate to call it a latent period, but a period of asymptomatic period, all of a sudden you get these we call it a great imitator. It's like you got a bad flu. I don't feel good. I get a rash. I don't know where this is coming from. I caught some kind of a bug, sore throat, the whole thing. Rash, fever, joint pain. And then they go away, and you think you're better. By this time, you haven't gotten any treatment. It's eminently treatable. Started that chancre or canker all the way into here and past this. Then it enters the true latent period, which can last for years. We're talking 10, 20, 30 years. And it may or may not, about half of them progress what we call tertiary syphilis. That's extraordinarily destructive all over the areas. Back in the day, they had people, it looked kind of like leprosy. You can imagine little pieces of their nose falling out, spots developing, weak spots, almost like soft spots that would break down. It was horrible. Horrible, horrible, horrible. And the horrible part about this is you're highly contagious. So maybe the first about halfway between, let's say for a couple of years in latency, and you can pass it on to unborn child. We had a lot of problems with congenital syphilis. It still responds by and large to penicillins very well. It is much more of a problem than people give it credit for. And then, of course, HPV, the most common sexually transmitted disease. Remember, chlamydia is bacterial. This is virus. Hello. I mean, the estimates are, I would dare say the estimates I've seen in various publications or on different websites, we're estimating, more than 50 million people have been infected, maybe 75 million in the United States. We call them venereal warts or genital warts, same virus that causes the standard wart, but there's different types. 80% of cases of cervical cancer. 15 to 30% of all cancers are directly caused by virus. This is the big player. All of these areas, penile, anal, oral, pharyngeal, the biggest uptick we see in these are oral pharyngeal from oral sexual activity. A ton of these. They are nasty. Trying to think of the right way. There's X number of types, and when you hear about Gardasil or the various other immunizations, they basically pick out the most common types that lead to. Not all types do. And the fact that somebody gets a wart, or the fact that somebody even gets a wart in the penile or vaginal or cervical area, does not mean that they're going to get cervical cancer. It means they need to be treated. That's the important part. And again, this goes back to frequent partners. A lot of times you don't see it. In the male, it's obviously more visible, etc. Boys and girls, and typically the age range used to be between 11 and 26. I do not know if this has changed. I had spoken, and unfortunately, the gentleman died some years ago, OB-GYN, and I asked him if he was having any problems, reactions to it. He said he never had difficulty with it. I mean, this was a long time ago, probably since 15, 20 years ago. He was still healthy and able to answer the question. This is almost as common, herpes. We don't see a lot of the signs that are there. And they're tiny blisters. They're sort of innocuous. They burn and they're sore, and then they go away. Long latent periods, and then when I say a vesicle, it's a little blister. Yeah, congenital herpes can be a real problem, particularly herpes type 2, which is the genital herpes, as opposed to herpes type 1, which is the oral herpes, although they can trade places anytime. Okay, and we have very good treatment for those in the antiviral drug. If you didn't get this in this is where Valtrex come in. They're called the aciclavirs. They're very, very effective treatments for this particular problem. Yep, we're done. All right, I'm going to look over the test, see if I didn't cover anything, and I will send that to you separately, and a little reminder, I'll type it out, And thank you very much. And there's no need to be in this afternoon, which is May 2nd at 2 o'clock. And I will send an email to that effect. Thanks again, and bye bye.